Usually when we think about mapping something, we imagine a GPS. Like, you type in an address, the satellite pinpoints the exact coordinates, and bam, there's a glowing blue dot right on your screen.
Right, it's completely objective.
Exactly. I mean, the destination exists in physical space, and there is no debate about whether or not that coffee shop is actually on that corner.
But when you try to map a destination inside the human body, well, specifically a place that some people swear is right there, and others claim is just a complete myth, your medical GPS just sort of ends up spinning.
Yeah, totally.
You leave the realm of objective geography and enter this highly subjective, heavily debated territory. It's the absolute definition of diagnostic muddy waters.
And welcome to the deep dive. Today, we are exploring a really fascinating tension in modern medicine, because on one side, we have the rigid mathematical precision of advanced medical imaging, where we're using artificial intelligence to track microscopic drops of blood.
Which is incredible on its own.
It is. But then, on the other side, we have this constantly evolving, highly subjective frontier of elective cosmetic enhancements, specifically procedures that are aimed at altering female sexual anatomy.
And what's interesting is what links these seemingly opposite fields together.
Yeah.
Because, we're pulling from a pretty diverse stack of sources today.
Oh, definitely.
We have highly technical radiology papers on AI-assisted cardiac MRIs and CT urography, paired right alongside clinical studies and marketing materials about female genital cosmetic surgery, specifically G-spot amplification.
Right.
And what ties them together is the fundamental challenge of gathering accurate data. I mean, measuring the exact volume of blood flowing through a beating heart and measuring a patient's highly subjective sexual satisfaction, they both run into the exact same hurdle.
Which is figuring out how to get a clear, reliable picture of what is really going on inside the body. Okay, let's unpack the hard math side of things first, because the lengths we go to for a clear picture are just wild. Take a standard CT urography scan, which doctors use to look at your kidneys, bladder, and urinary tract.
Right, a very standard diagnostic tool.
Yeah, but from what I understand, they usually inject a patient with a contrast dye and run them through the scanner 3 separate times just to watch the dye move. But doing that exposes the patient to, a lot of radiation, doesn't it?
A significant amount, yes. The traditional method requires multiple scans because your urinary system processes fluids in stages.
Okay, so it's not all at once.
Right. You need one scan for the unenhanced phase, before the dye does anything, then one for when the dye hits the kidney tissue, and a third scan later when the dye finally pools in the bladder and ureters.
That seems like a lot of scanning.
It is. But one of our sources, a study from the Journal of the Institute of Medicine DePaul, tested a clever workaround to cut down on that radiation. It's called the split-bolus technique.
Okay, wait, how does splitting the injection help if you still need to see all those different stages?
By turning time into a tool. So instead of one big injection and 3 separate scans, they gave the patient a smaller 40 milliliter injection of contrast dye. And then they simply waited.
Just waited. For how long?
For exactly 9 minutes, they just let the patient's body process that dye. And during those 9 minutes, the contrast filters down through the kidneys, through the ureters, and eventually settles into the excretory phase.
Oh, meaning it's lighting up the bladder and the lower urinary tract.
Exactly.
So basically the first batch of dye is already at the finish line.
Right. And then they inject a second larger dose of 60 milliliters. But this time, they wait just 90 seconds for that new dye to circulate into the bloodstream and hit the kidney tissue.
The corticomedullary phase, right?
Yes. And at that precise moment, they run the patient through the scanner just once.
Oh, wow. That makes so much sense. I mean, it's like exposing the same piece of photographic film twice to capture 2 different moments in a single picture.
That's a great way to think about it.
Yeah, you get the beginning of the dye's journey and the end of the dye's journey perfectly overlaid in one image, and you didn't have to fire off the camera's flash, or I guess in this case, the radiation, 3 separate times.
And the impact on the patient's health is substantial. By combining the phases into a single imaging session, the mean effective radiation dose was reduced by a massive 40.5% compared to the traditional method.
Wait, 40%? That's huge.
It really is. They achieved the exact same diagnostic clarity with nearly half the cellular damage. What's fascinating here is that we see the same intense drive to optimize the image when we look at cardiac MRIs.
Right, I was reading about that. When cardiologists want to measure a myocardial blood flow, which is literally just how well blood is perfusing into the heart muscle, they also use a contrast agent, usually gadolinium.
Yes, gadolinium is the standard.
But there is this physics problem here that I don't quite grasp. The sources call it signal saturation. So what is actually happening to the MRI machine?
Well, gadolinium is highly magnetic, which is why it shows up so brightly on an MRI in the first place. But when it's first injected, it travels in a very dense, concentrated cluster through the arterial blood before it has a chance to spread out.
Okay, I'm with you.
So when that incredibly dense cluster of gadolinium passes the scanner, the magnetic resonance signal becomes so strong that it actually stops being linear.
What does that mean, practically?
It means the machine's sensors essentially hit a ceiling. They can't measure any higher, even though the actual concentration of the dye is still increasing.
Oh, I get it. It's like someone screaming directly into a sensitive microphone. The audio just clips and distorts. You know the sound is incredibly loud, but the waveform is just a flat block, and you lose all the actual detail of the person's voice.
That is a perfect analogy. The true peak of the signal is completely lost. So to fix that overexposed, blown-out data, researchers brought in a specific type of artificial intelligence.
A 1D UNet deep learning model, right?
Exactly. It's a neural network designed specifically to process one-dimensional signals over time, and they trained this AI using a slow, meticulous, gold standard technique called a dual sequence acquisition.
But that's not something they can just use for every patient.
No, it's highly accurate, but it's way too complicated and time-consuming for everyday clinical use.
So they feed the AI thousands of examples of what the perfect unsaturated signal is supposed to look like, alongside the broken, clipped signals from a normal scan.
Right. And the AI learns the underlying patterns. It looks at the distorted saturated curve from a fast, standard scan and predicts what the true unsaturated arterial input function, the AIF, should be.
And did it work?
It did. When they tested it, the AI's prediction matched the gold standard perfectly, with a minuscule bias of negative 0.11 milliliters per minute per gram.
Wow. So it is acting exactly like a smart audio filter that takes that blown-out screaming from the microphone and magically restores the lost frequencies so you can hear the exact words again.
Precisely. And in cardiology, as well as urology, this absolute mathematical quantification is the entire goal. I mean, we know exactly where the heart is. We know where the prostate is.
Right. The anatomy isn't a mystery.
Exactly. The challenge isn't finding the organ. The challenge is calculating its function with perfect clarity. For example, in prostate cancer imaging, researchers look at the way contrast dye moves to hunt for specific mathematical parameters. They often use something called the Tofts model.
Yeah, I saw the Tofts model mentioned with all these complex variables like KIO and KP, but what do those letters actually represent inside a patient's body?
They measure how aggressively a tumor is feeding itself. You see, cancerous tumors grow so fast that they build shoddy, disorganized blood vessels, and those vessels are notoriously leaky.
Okay, so they're looking for the leaks.
Right. The Tofts model is essentially a mathematical equation that calculates the exact rate at which the contrast dye leaks out of a capillary and into the surrounding tumor tissue. KO and KP are just the formulas for that transfer rate.
So if a doctor sees a high leak rate, they know for a fact they are looking at aggressive cancer cells and not just healthy prostate tissue.
Yes. And because those numbers dictate life or death treatment decisions, they must be what we call scaling insensitive.
Meaning what, exactly?
Meaning the math has to hold true regardless of whether the initial injection of contrast dye was a little too concentrated or if the scanner had a slight saturation issue. We demand absolute, verifiable certainty from the data.
Which brings up a really fascinating contradiction. I mean, if we have deep learning algorithms that can track microscopic drops of blood leaking from a capillary in a prostate to the exact decimal point, why is female anatomy, specifically the G-spot, still treated like this unsolved medical mystery?
Well, we have to distinguish between static anatomy, like a kidney or a prostate, and a functional sensory zone.
Okay.
The G-spot was first described in scientific literature by a German gynecologist named Dr. Ernst Grafenberg back in 1950. He located an erogenous zone about 1 to 3 inches inside the anterior vaginal wall, roughly 2 centimeters below the urethra.
But even decades later, the scientific community still argues over its existence, right?
They do, mainly because people have historically looked for a discrete, standalone organ.
Like a light switch that you can just point to on an anatomical chart.
Exactly. But modern anatomical consensus has moved far away from the button theory. It is increasingly understood as the clitorithrovaginal complex, or the CUV complex.
COV complex, got it.
This isn't a single structure, it is an intersection. It's where the internal branches of the clitoris, the urethral sponge, which naturally swells with blood during arousal, and a high density of vaginal wall nerve endings all converge. So it's a highly complex neurovascular network.
But you mean even if it's a network, it's still physical tissue? Going back to our imaging discussion, there was an MRI observational study by Maratus and colleagues that tried to map the CUV complex in living patients. Why did standard MRIs completely fail to spot it at first? If we can see a leaky capillary, why can't we see a dense network of nerves and erectile tissue?
Because you can't map a collapsed cave.
The collapsed cave.
Yeah. In a resting state, the vaginal walls naturally collapse and rest against each other. So on a standard MRI, all of those anterior wall structures are compressed into a single, indistinguishable line of tissue. The contrast between the different structures is completely lost.
Oh, I see. So how did the researchers finally get a clear picture?
They used sterile ultrasound gel to opacify and distend the vaginal walls. By filling the canal with inert gel, they literally forced the walls apart and created physical space.
Ah, so the gel essentially inflated the cave, providing contrast against the surrounding tissue.
Exactly. Once that space was opened up, the researchers were able to identify the distinct structures of the G-spot complex in 100% of the opacified patients.
Wait, 100%. So 10 out of 10 patients had the physical landscape. It just required a creative technique to actually illuminate it.
Right.
But if we finally understand that this area is a complex, delicate intersection of nerves and erectile tissue, what happens when boutique medicine tries to physically augment it?
Well, that moves us from diagnostics into the commercial application known as G-spot amplification, which is commonly marketed to patients as the G-shot.
The procedure itself sounds surprisingly simple for something targeting such a debated area. It's an in-office procedure done under local anesthesia that only takes a few minutes.
Very quick, yes.
The physician takes a needle and injects a filler material directly into the submucosal layer of that anterior vaginal wall. The goal is to create a physical cushion, usually described as being about the width of a quarter and projecting roughly a quarter inch into the vaginal canal.
And clinicians use a variety of materials to create that cushion. Many use cross-linked hyaluronic acid, or HA. Others use collagen.
Are there other options?
Yes. Some use autologous fat, which they harvest from the patient's own body via a mini liposuction. And there's also the use of platelet-rich plasma, or PRP, which is often marketed separately under names like the O-shot.
You know, here's where it gets really interesting. The off-label use of these materials is wild to think about. Hyaluronic acid is the exact same standard dermal filler that plastic surgeons use to plump up lips or smooth out deep wrinkles on a patient's face.
Yes, it's very common in facial aesthetics.
And collagen injections in the urethra have a totally different medical history, don't they?
They do. Urologists have historically used collagen injections for elderly women suffering from intrinsic sphincter deficiency. When the urethral sphincter weakens and causes urinary incontinence, doctors inject collagen into the surrounding tissue to bulk it up and help close the urethra.
So they are taking materials designed to stop urine leakage or smooth out facial wrinkles, and they're repurposing them purely for sexual enhancement. How does adding a quarter-sized bump of filler actually translate to increased pleasure?
Well, the clinics operating in this space promise that by making this erogenous zone physically larger and more prominent, it becomes significantly more accessible to tactile stimulation during intercourse.
Just by making it stand out more.
Exactly. The theory is that this increased friction and accessibility leads to heightened sensitivity, enhanced arousal, and easier vaginal orgasms.
But the results aren't permanent, right?
No, because all of these materials naturally degrade and are absorbed by the body over time. The results are temporary, typically lasting anywhere from 3 to 12 months. Fat grafting tends to have a slightly longer structural life than hyaluronic acid, but it still fades.
Wait, thinking back to our discussion about the CT scans and the split bolus technique, where they strategically split the injection into two phases because the urinary tract is a long, complex system.
Right.
If the G-spot isn't just a tiny quarter-sized dot, but is actually the CUV complex like, a much wider anatomical zone of nerve endings and clitoral roots, does it even make sense to just inject one single lump of filler right in the center? Could a doctor use, say, a dual-bolus injection technique here, injecting distally and proximally to cover the whole functional area?
That is a very sharp parallel to draw. And interestingly, the clinical practice actually reflects that exact logic in some places.
Wait, really?
Yes. Because the CEV complex is a diffuse neurovascular zone rather than a pinpoint target, some clinics have adapted their injection strategies. Our sources highlight a clinic in Geneva run by a Dr. Romano, which specifically notes that during their procedure, they do not rely on a single central puncture.
Oh, wow. So what do they do?
Instead, two distinct injections are performed, one on each side of the midline.
So they are literally adapting the physical injection to match the reality of the wider anatomical map. They are distributing the filler to capture the full functional area, just like you'd adjust contrast dye for a wider scan.
Exactly, they recognize the broader zone. But this leads us to the most contentious part of the deep dive, the evidence. Does this procedure actually deliver on its promises? Reconciling subjective patient reports with strict, evidence-based medical guidelines reveals a pretty profound divide in modern medicine.
Yeah, let's talk about the data, because a pilot study published in the JSM Sexual Medicine Journal certainly makes it look like a miracle cure.
What did they find?
They took 16 sexually active women and split them into two groups. One group received the hyaluronic acid filler, and the other received the platelet-rich plasma. And to measure the outcomes, they used the Female Sexual Function Index, or FSFI, which is a validated questionnaire that tracks things like desire, arousal, lubrication, and orgasm.
And the reported results from that pilot were quite striking. The hyaluronic acid group saw a 68.1% improvement in their total FSFI scores.
Over 68%, that's huge.
It is. They saw massive spikes in the arousal and orgasm domains specifically. And the PRP group also reported a significant boost, showing about a 45.7% improvement overall.
I mean, if you are a patient struggling with sexual dysfunction and you read a pilot study showing a 68% improvement, you are going to book an appointment immediately.
It's definitely compelling.
Yeah.
However, if we connect this to the bigger picture, you have to look at the broader landscape of clinical evidence, which includes significant counter-evidence. For instance, the Journal of the Turkish-German Gynecological Association published a detailed case study of a 29-year-old woman who underwent G-spot amplification using autologous fat. And the volume injected was massive, a full 8 cubic centimeters of fat grafted into the anterior wall.
8 cubic centimeters. That is a huge amount of volume for such a delicate space. Did it actually work?
Initially, she reported heightened sensitivity, which lasted for about 2 weeks. But the researchers didn't just ask her how she felt in the moment. They rigorously tracked her progress over 20 months using standard psychological and life satisfaction questionnaires like the FLZ.
And what did the long-term data show?
Over that extended period, the questionnaires showed absolutely no long-term positive effects on her subjective well-being or her sexuality. The sensation faded as her body acclimated, and the researchers concluded that their scientific evaluation failed to prove any real clinical efficiency for the procedure.
Wow. And that single case study perfectly illustrates why major medical governing bodies are throwing up red flags left and right.
It's exactly. The American College of Obstetricians and Gynecologists, known as ACOG, issued a very blunt committee opinion on this opinion number 795. They strongly caution against all elective female genital cosmetic surgeries, including G-spot amplification.
And their opposition isn't just about being conservative, is it?
No, it's rooted entirely in the demand for objective, reproducible data. ACOG states unequivocally that there is a severe lack of high-quality, randomized controlled trials. From a strict institutional medical standpoint, the safety and effectiveness of these procedures are simply not established.
Plus, they list some pretty severe potential risks that the boutique clinics don't exactly put on their glossy brochures. We are talking about scarring, tissue adhesions, permanently altered sensation, and dyspareunia.
Dyspareunia being the medical term for persistent severe pain during intercourse, which is, the exact opposite outcome a patient seeking sexual enhancement is hoping for.
Absolutely. So what does this all mean for you listening right now? When you look at all of this together, it becomes clear that we are operating in two entirely different medical realities. On one hand, you have boutique clinics relying on pilot data, anatomical theories, and highly subjective patient reports of sexual satisfaction.
Right.
But on the other hand, you have massive institutions like ACOG that demand rigorous, quantifiable mathematical proof. They want the medical equivalent of that AI-driven cardiac MRI before they will ever endorse a cosmetic procedure as safe and effective.
It forces us to question the very nature of what is actually being measured. I mean, a blocked artery or a leaky tumor capillary is an objective medical crisis. You can see it, you can measure it.
Yes, exactly.
But sexual satisfaction is a deeply subjective human experience. It is heavily influenced by a person's psychology, their relationship dynamics, past traumas, and individual neurobiology. A physical dermal filler cannot fix a psychological hurdle. Ethical clinicians who perform these procedures are usually very upfront about screening out patients whose sexual dysfunction is psychogenic rather than anatomical.
Because you can't just inject hyaluronic acid into an emotional disconnect. Being a well-informed patient today means knowing how to spot the difference between a highly regulated medical diagnostic and an elective, subjective enhancement. It is about protecting your own health by understanding when the science is settled, like knowing exactly how much radiation a split-bolus CT scan saves you.
Exactly.
And knowing when the science is still an off-label experiment relying on trial and error. I mean, look at the journey we've covered today. We have evolved from using deep learning algorithms to track the exact milliliter of blood flowing through a heart to injecting facial fillers into a debated anatomical zone just to chase the subjective feeling of pleasure.
Which leaves us with an important, provocative question to consider. Medical imaging is advancing at lightning speed, as we've seen. We are using ultrasound gel to finally illuminate the CUV complex on an MRI, and we are using advanced AI neural networks to clean up saturated data signals in the heart.
The technology is incredible.
It is. So, if one day technology allows us to map the precise microscopic neural and vascular pathways of human pleasure with perfect mathematical clarity, will cosmetic procedures like the G-shot finally become an exact, measurable science?
Or is the subjective nature of human sexuality, the sheer emotional and psychological weight of it, something that will always defy a purely physical anatomical fix? You can map the coordinates perfectly and you can put the glowing blue dot right on the screen, but just because you know exactly where the destination is doesn't mean you can guarantee how the journey is going to feel. Thanks for joining us on this deep dive. Keep questioning the map, and we will catch you next time.